All right. We are in record mode. Perfect. Well, thank you so much for everyone joining today. It's lovely to see so many great leaders here who will be joining us to learn so many great information, especially through our amazing guest speaker today. So today we are meeting with the purpose of learning more of the CHW Building and Sustainability Collaborative. And this meeting today is an information session. Okay.
No,
Ignored. Okay. So just a brief overview of what we will cover today. I'll briefly share and welcome everyone and share some instructions. Purpose of today's collaborative. I'll introduce our wonderful guest speaker, in which Ms. Mary Zavala will present on the community health workers and Medi-Cal training for this group. And then we will transition into providing some next steps and then opening up to focus on the questions that you all will hopefully you all can provide some questions, and then we'll answer those questions towards the end. So I would like to welcome you all to this CHW Building and Sustainability Collaborative. If you have some time and you're able to, I know some of you are multitasking, if you can add your name, title, and organization, optional your email, if you would like to stay in connection with this group into the chat, that would be greatly appreciated. I also have an activity, a Mentimeter activity. If you can scan that QR code, or you can type in using a separate tab, type in menti.com, and that is the code shown, code 93991383. I'll go ahead and also add it to the chat. There we'll do just a very brief poll to see the landscape of our current participants. So the first question will be geared to adding what type of organization is present. So let me go ahead and share my screen so that we can see it together. So go ahead and click on the type of organization that you are representing so that Ms. Mary can see the landscape of those who are present today. And this can possibly guide some of information that she will provide. So far we have 5 hospitals present. Awesome. We have 2 federally qualified health centers. Wonderful. A clinic. All right, more hospital folks. Great. Wonderful. 3 federally qualified health centers, 1 nonprofit, partner with healthcare systems. Wonderful. So far in our meeting today, we have a leading participation of hospitals. So this is really great to know. Hopefully this is helpful for Mary as well. And then the following slide, which I'll briefly show, is if you can add in questions at any time, submit questions as we're going through the presentation, and we will cover and address them towards the end. The questions or your participation is anonymous, so at any time you want to create a question or mention a question or make a comment, go ahead and add it to this Mentimeter, and that way once presentation is complete, we'll come back to this screen and this slide, and we'll go over those questions. So feel free to type in your questions throughout the presentation rather than putting it on the chat, because again, it's anonymous. So you can feel free to ask questions. Okay, coming back to the presentation. So I'd like to share a brief overview of the purpose of the CHW Billing Sustainability Collaborative. The main goal here is to support our CHW Academy partners and our CHW allies. Some organizations that are here today are not currently our partners with the CHW Academy, but we do collaborate with them in different capacities. So we want to support them as they build sustainable Medi-Cal billable CHW programs by offering shared learning space like this one, resources and technical assistance through convenience like this one today. My role specifically is to bring the partners together, allies together to foster shared learning, identify new barriers so that we can continue to learn from each other and offer technical assistance, such as bringing in guest speakers that are experts out in the field, and any insights that I gain through any statewide CHW billing efforts. So that's my role here for the CHW Billing and Sustainable Collaborative. Again, please submit your questions at any time, and we'll come back to these questions towards the end. Okay, it is my pleasure to introduce our wonderful guest speaker, Ms. Mary Zavala. I'll briefly do a synopsis of her bio since I had already previously sent it to everyone here. She has extensive experience in CalAIM and managed care Medi-Cal, specifically focusing on enhanced care management. As my understanding, she worked for LA Care Health Plan as well. So this will be essential for us as a group to learn from her. She worked in different capacities and programs with enhanced care management and community support. So it's an honor to have her here today. And my great gratitude goes out to her as she will lead us in teaching us more about CHW billing pathways and sustainability. Thank you, Mary. I'll pass it along to you.
Sure. Thanks, Rosie. Hope you guys can hear me okay. Can you hear me? Great. Okay. I'm super excited to be here. As Rosie mentioned, I work as a healthcare consultant. I have worked with many of your organizations, or am familiar with many of your organizations. My work in LA County spans more than 20 years. I am a licensed clinical social worker, so I started my work in direct clinical practice in some hospitals and clinics. And then over time moved into managed care to be able to integrate some of that really important community-based work in the initiatives that Medi-Cal is working on. And now as a consultant, I get to help great community-based organizations and providers come into the Medi-Cal space and be able to really make a difference. So it's very exciting for me to be here to talk with you all today. Can we go to the next slide? Great. All right. So we are going to do a little training and overview on community health workers and Medi-Cal. So I want to be clear from the outset, there are a lot of things community health workers can do, and a lot of ways community health workers work in the community. When we talk about the Medi-Cal CHW benefit, we're talking about kind of a narrower vision of that. So I want you to keep that in mind. I'm not saying that this is the only way CHWs can work, but if you want to bill and be reimbursed under the CHW Medi-Cal benefit, these are the pieces that apply. So keep that in mind. We can go to the next slide. All right, so I'm here on behalf of Public Works Alliance. I work with Public Works Alliance, which is a social justice nonprofit focused on creating stronger and more equitable public systems by shifting power and agencies to the communities that they serve through systems design and workforce development. Next slide. I think this is the same thing, so you can skip this one. Why? Okay. So before we dig in, I think some context setting and talking about the landscape really matters here. So why does Medi-Cal matter now? I think every time we turn on the news or we look online, we're hearing about different changes that are coming down, whether it's federal policy, state policy, healthcare coverage changes. I think all of our organizations are facing periods of uncertainty financially, health insurance coverage wise, based on immigration, changes to Medicaid eligibility federally. And so all of these things matter. In California, we have, over the last 5 years, implemented what's called CalAIM. I'm sure many of you have heard CalAIM, and maybe you've heard it too much, but that stands for California Advancing and Innovating Medi-Cal. And so what has happened over the last 5 years in California is that we have opened Medi-Cal to recognize that support to address health-related social needs or social drivers of health is important to address overall healthcare. And so what this means is now systems of care have expanded beyond just traditional healthcare providers, including hospitals and clinics, to include CBOs, to include other community organizations that employ staff like community health workers to be able to help our Medicaid recipients and our Medi-Cal members be able to address their health, including their social needs. That relationship has to include managed care plans. In Los Angeles County, we have 6 Medi-Cal managed care plans: LA Care, Health Net, Molina, Anthem, Blue Shield Promise, and Kaiser Permanente. And they are the ones that receive the money from the state to be able to pay for those benefits. So inherent in being able to work on this and have this successful system, there has to be a relationship between the community-based providers and the managed care plans. And so because that has been created over the last 5 years, there are now new pathways to participate as Medi-Cal providers that didn't exist before. And so that is a really important context to understand as we talk about billing for the community health worker benefit. Next slide. Oh, yep. Okay, there we go. So what are some of the new reimbursable career pathways? This is a great slide because it talks about all the different ways that culturally grounded providers and providers with lived experience can support families and children and individuals who have had a number of different adverse experiences. So peer-to-peers in schools, peer specialists, community health workers, wellness coaches, dyadic care. Then we also will probably mention enhanced care management, community supports, and others. So there are so many opportunities that are outside the traditional medical healthcare spectrum for organizations to participate in Medi-Cal and bring that community-based knowledge to practice and to have an impact. So it's really important to be aware that there are a variety of settings and a variety of ways that you can engage in this service delivery. Next slide. So this is really important as well because eligible provider classes. So when we say eligible provider classes, we're talking about new provider types, like a community health worker, like a CBO, not just a doctor or a nurse or a social worker or a behavioral health clinician. These create an opportunity to help make services like mental health and like other services more relevant and more accessible. It matters a lot if you have an immigrant who is receiving services in their native language from someone who looks like them than maybe someone who looks like me, right? And so being able to be culturally concordant, excuse me, have some shared lived experience, that is going to be something really, really critical, especially in a time of a lot of misinformation and distrust. So it's more important now than ever. Next slide. All right. So you can go ahead and have all of them load, Rosie, if you don't mind. So opportunities again. So we're integrating new non-clinical benefits like enhanced care management and community supports. We're adding new mental health benefits like dyadic care and family therapy. We have new provider classes, including community health worker, doula, peers, and wellness coaches. And then there are new opportunities to partner with schools on fee schedules, to bill case management and psychoeducation. So all of these are different opportunities that didn't exist even 5 years ago, and ways that non-traditional providers can come into the Medicaid landscape. Next slide. So to sum it all up, CBOs can and must be essential actors in the response. Next. And having the message conveyed by a credible messenger is really critical. All right, so we're going to talk about the community health worker benefit. Again, we're taking a little bit of that narrow lens into what's reimbursable under the Medi-Cal community health worker benefit. So we're going to talk about what it is to be a CHW, to qualify as a community health worker that can bill Medi-Cal. What are the services that a CHW can provide under Medi-Cal, and who you can serve? Who are the eligible clients or members? Next slide. So we start here with a couple of client vignettes. I'm hoping that one or both of these resonate with you as potential members or patients that you're working with. So this example is Katie. Katie's a 21-year-old mother who's pregnant with her second child. She's working with a child welfare agency to regain custody of her 2-year-old daughter, as well as to learn parenting skills as she prepares to give birth again soon. She lives in a small apartment, works a part-time job, and barely earns enough for rent and food. She has no family locally and has left her partner due to interpersonal violence. Though her mother and extended family are supportive of her, they can't offer much help. Her mom is also a single mother who struggles to provide for Katie's younger siblings. So in addition to needing help navigating the care system to address the trauma of the domestic violence she experienced, Katie also has gestational diabetes and has found this to be one of the most challenging parts of her pregnancy. How could a community health worker help Katie? So she could get help accessing care for her physical and behavioral health needs, and receiving education about gestational diabetes, maybe help getting access to proper prenatal care, parenting strategies to support her 2 young children, and potentially getting connected to other services. So maybe a doula would be great for Katie. Getting her connected to some medically tailored meals, things like that. So there are a lot of ways a community health worker who has a shared lived experience could appeal to Katie and could be a great partner for her in navigating the system. Next slide. Daryl is our other sample client here. And he's a 65-year-old retired male who lives alone and has been serving as a guardian for his teenage grandchildren. He has owned the home he lives in for more than 30 years. Daryl was recently diagnosed with diabetes, heart disease, and had to have one of his toes amputated. He needs a cane to help get around. And his surgical recovery has been challenging and limited his ability to get out of the house. He was also told that he needs to stop drinking alcohol and using marijuana, which he did regularly to help him cope. He's finding the changes in his life saddening and overwhelming, but wants to continue to be there for his grandchildren, but he struggles to manage his own needs. So a CHW potentially could help Daryl access health education services, get connected to substance use treatment, overall healthcare navigation, maybe find some socialization activities, other ways to help him adjust to the new circumstances of his own health and make sure that he's able to be in his best mindset to support his grandchildren. Okay. So what is a community health worker when we talk about CHW in the context of Medi-Cal? In Medi-Cal, community health workers must have lived experiences similar to Medi-Cal members and or be trusted members of their community. So what does this mean? Does it mean that it can mean that you are from a similar cultural or linguistic background? It can be that you've had similar life experiences to perhaps a former foster youth, someone who was previously incarcerated, someone who was previously homeless, someone who previously struggled with substance use disorder, someone who is a parent and has worked through challenges as a parent. So some way that they align with that community that they're serving. Community health workers also help address chronic conditions, preventive healthcare needs, and health-related social issues. So this is a really important piece, and we'll come back to that. They must be 18 or older to bill Medi-Cal, so you have to be a legal adult. Next slide. Here are some more examples of lived experience. So again, shared race, ethnicity, sexual orientation, gender identity, language or cultural background, and or experiences like previously incarcerated, previously in the military, previously pregnant and gave birth, or experienced a loss, disability, foster care system involvement, community or independent party violence, a history of addiction, mental health conditions, or previously homeless. So remember, what we're trying to do here is create an environment where we're reaching the very hard to reach. We're inviting them in and we're connecting with them on that lived experience basis. Makes a lot of difference for clients who don't trust, who are not engaged, or have been previously marginalized from the system, when they have someone who looks like them, speaks like them, or hasn't had an experience like them to bring them into service. Next slide. So under the Medi-Cal benefit for community health worker, community health workers can provide services including health education, like coaching and goal setting, some kinds of screening and assessment. This is screening and assessment that's appropriate for someone who's not licensed, not clinically licensed. They can provide advocacy to prevent disease, disability, and other health educations, provide health navigation, understanding the system and accessing care, and being a cultural liaison. I want to say that last part, that's really, really important, especially right now where we're in a time, I think, from the COVID pandemic, even continuing now, where there's a lot of misinformation that's circulated in the community, especially communities of color, where there's fear and again, some marginalization. Community health workers can be a very strong role and tool to help overcome some of that misinformation and marginalization. So this is a really important time to be that cultural liaison, be that trusted messenger to be able to help individuals navigate their healthcare at a time when they feel like maybe it's not safe to do that. And under the CHW benefit, you can provide up to 2 hours a day per beneficiary or per Medi-Cal member as reimbursable. The last thing on here that I'll save, since we have some clinics and FQHCs in the room, you probably already know this if you're a clinic or an FQHC, but FQHCs cannot be reimbursed for the community health worker benefit in addition to your prospective payment system or your PPS rate. So we'll talk about ways that community health workers, CBOs, and FQHCs can partner together to bring CHW services to FQHC patients, since FQHCs cannot bill Medi-Cal directly for the CHW benefit. Next slide. So this is a little bit more detailed explanation of what those CHW service scenarios look like. So helping someone connect to behavioral health services, helping someone understand and get education about a chronic condition, helping someone know how to prevent infections, offering services, helping someone access services for sexual or reproductive health, connecting them to prenatal and postpartum care and helping them understand why that's important. Helping someone get to preventive appointments, including cancer screenings, immunizations, well child visits, helping someone who is a victim of domestic violence get connected to DV resources, helping someone get necessary resources following an injury, helping them get connected to dental services. And then number 10 is really important. I want to call this one out again, benefits enrollment, helping a member get access to needed and related services. So this can include government services if they're connected to their health related social needs. So we know coming into 2027, there's going to be much more frequent renewals of Medi-Cal, right? This is part of the federal change under the Big Beautiful Bill, where Medi-Cal beneficiaries will have to do renewals twice a year. Community health workers can be a big help in helping individuals navigate that process, and that is a covered service under the CHW benefit. So that's an example of number 10 here with the benefits enrollment, helping someone maintain their Medi-Cal coverage so they can have access to all these other things. Next slide. Things that CHWs cannot do. So they don't provide personal care. You're not a personal care aide or respite care. Other services Medi-Cal already covers, including things that are duplicated like enhanced care management, socialization, providing direct transportation. You can help coordinate transportation, but actually driving members somewhere is not an approved service. Services that require a clinical license, peer support services, clinical case management, childcare, companion services, helping someone enroll in a non-health or government assistance program, and then providing medication, medical equipment, or supplies. So it's good to have this list because I think it's helps clarify what's in scope and what's out of scope. Next slide. So this is the other very important piece I want you all to think about. When the community health worker benefit was designed, it was designed as a preventive service. So I would guess many of you have probably heard about enhanced care management or ECM as a Medi-Cal service. ECM is intended to support the highest risk Medi-Cal members or the top 3 to 5% of Medi-Cal members. So you have to be really, really high need very intense services to qualify for enhanced care management. Unlike that, community health worker benefit was created as a preventive service and has very broad eligibility. So in my own practice, I can't think of one Medi-Cal beneficiary I've ever worked with that could not qualify for CHW services. This is accessible to most of the people you probably serve today, as long as they have Medi-Cal. If they have one or more chronic health or behavioral health conditions, they can qualify. And they only have to have one of these, by the way, so they don't have to have more than one. If they're at risk or they have indicators of chronic disease risk, so if someone's following them for their A1C because they're pre-diabetic, or they have elevated blood pressure, but they haven't yet been diagnosed with hypertension, they can qualify for community health workers benefit. They have risk factors such as experiencing domestic violence or tobacco use or excessive alcohol or drug misuse. If they've missed 2 or more medical appointments within the last 6 months. If you do a screening like the Prepare that shows that they have unmet health-related social needs, such as housing or food insecurity, they can qualify. If they screen positively on an ACEs screening tool, so like the Pearls or some other ACE screening tool, if they've been to the hospital 1 or more times in the last 6 months, if they've been to a detox facility 1 or more times in the last year, if they are showing signs that they might need to be placed within an inpatient care or a facility for ongoing management because they're at risk for institutionalization, they can also qualify for community health worker services. If they need help securing preventive services, cancer screenings, immunizations, or if they ask for help navigating the healthcare system or help coordinating resources. So I want you to think about this in the context of the patients and the clients, members that you work with, and think about probably how many of them could meet one or more of these criteria. It's pretty significant when we think about how many people could get services. The other thing that's the note on the bottom that I want to call out, which is especially important in the context of Medi-Cal changes due to immigration status, is we're always trying to think of what do we do to help families where maybe mom or dad don't have satisfactory immigration status, but children were born here and are citizens and can receive Medi-Cal. So if we have a child who's under the age of 21 and is present with mom or dad, services can be provided to for the direct benefit of the child, but also with mom and dad present. So if they need help navigating the healthcare system and mom or dad doesn't have Medi-Cal and the child is there, there can be CHW benefit services that help the child, but also additionally help mom and dad. So that's a way to make sure that we're supporting family members who maybe don't have their own line to Medi-Cal, but could benefit from information. Next slide. The addition is for this additionally is for individuals who have been exposed to or are experiencing violence. So this is violence prevention CHW services, and this includes individuals who have been injured violently as a result of community violence or are at risk of violent injury because of community violence or have been chronically exposed to community violence. Next slide. All right. So we've talked about what a CHW is, what they can do, and who they can serve. The next thing is how do we actually make this happen? And this is more of the behind the scenes nuts and bolts of providing services so that you can make sure you get paid for them. There are 3 pathways that we'll talk about. So the first one is a traditional community-based pathway. The second is a medical pathway, and the third is combining those 2. So we'll talk through each of those. Next slide, please. So the CHW community-based pathway is a CBO or a CHW employing organization. So an organization that employs CHWs, receives referrals from maybe a partner agency, internal referrals if you're already providing some kinds of programs and services, or other external referrals, maybe from a managed care plan or something like that. And these are your potential clients. So you would receive those referrals, you would need to check that their Medi-Cal coverage is active and by one of the health plans with whom you are contracted. So if you're contracted with LA Care, the referrals would need to be for individuals who have active Medi-Cal coverage with LA Care. Then you can begin to meet with the client and identify the needs for services. They're under the community-based pathway. There are 12 units of service that are approved, and that equals 6 hours because 1 unit equals 30 minutes. So 12 units is 6 hours of service. So you can provide up to 6 hours of service and make a decision about whether that has met the client's needs and end services. Maybe their need is resolved. Maybe they need more intensive services and would qualify for a higher level of care management. Or maybe there are still things to work on and the CHW benefit is right for them. And so you could ask the health plan if that services could be extended. So again, this is when we think about enhanced care management, community health worker is a shorter term intervention. It's a lighter touch, right? And we're talking about preventive services. And we could use this as a way to identify individuals who need longer term, more intense services under other programs. So this is a perfect illustration of that shorter term, lighter touch, initial intent for CHW services. Next slide. Okay, so this talks about the rates, and this is where the rubber hits the road. And it's challenging, I'm not going to lie. So there are 3 billing codes that you can use for community health worker services. The rates are low, you guys. So this is what makes it hard. A 30-minute session with 1 patient is reimbursed at $27.43. So really one of the considerations that you have to think about, and we'll come to this later in the slides, is what other funding sources am I bringing together to supplement and make us whole? Because $27.43 for 30 minutes is not going to be sustainable for an organization. In this community-based model, you can also do group CHW services. So if you have 2 to 4 members, you can bill the 98961 code, or if you have 5 to 8, you can bill the 98962, and those are reimbursed at different dollar amounts per individual. So if you have 5 to 8 individuals, each individual is reimbursed at $9.77. So potentially you could earn more in a half an hour if you have a group, but that again requires coordination, and there's more work there. Okay, next slide. So the medical pathway, and this one has an asterisk on it, it's included in the DHCS Community Health Worker Program Guide. It is not yet fully implemented across the state because the managed care plans are waiting for some finalized guidance from the Department of Healthcare Services, or DHCS. So this one is forthcoming. We believe it will be coming soon. And the great thing about this model is it offers longer services. It offers services for up to 12 months, and it reimburses at a much higher rate. So we'll come to that in a second. This pathway is also a little more complicated because it requires that the patient or the client starts with an initiating visit with a licensed Medi-Cal provider. So those of you that are clinics or FQs, a patient would have to come in, see their doctor or their PA or their NP, and the doctor would have to say, I'm having trouble diagnosing you because there are so many complex social needs that are interfering with us being able to come to a diagnosis and treatment plan. So for example, I see that you have diabetes and you're non-adherent with your insulin, but I can't really figure out the right treatment plan because you don't have a refrigerator for your insulin. You're non-adherent because you don't understand how to take it. We need to help you get to nutrition classes. There are a lot of things interfering with us being successful here. And so I'm going to refer you to a community health worker who can help us address some of those social needs so that we can come back and make a correct treatment plan or a best fit treatment plan for you. So they must have this visit with a licensed Medi-Cal provider. And then that provider must work with the CHW to create a care plan that is going to address those barriers that they've identified in that initiating visit. And then CHW services can start. So you can provide up to 3 hours per month. The first unit is 60 minutes, so 1 hour. And then subsequent, you can have 30 minutes units for a period of up to 12 months. So multiple sessions. That care plan gives you a year of service. And then after that year, you can choose the same 2 options, whether you choose to extend it because more work is needed and a new care plan gets developed with the provider, or end the service because they've either completed their goals or they need to be referred to a different level of care management like ECM or something else. So this one is more work. If we go to the next slide, I'll show you the difference in rates. So that first hour-long unit can be $80 for an hour. And then those 30-minute units can be up to $50 based on the Medicare rates. And so this is one of the things that the health plans are waiting for from DHCS is confirmation of the rates. But based on what we think they will be around $80 for that first hour and $50 for every 30-minute unit after that. Okay. The third model is a combination of these two. And if we're thinking about sustainability, this is a really important consideration is can you blend those two models together to reap the benefits of having a community-based referral pathway and having a medical pathway where you're going to have that higher reimbursement rate. So having a blended pathway for referrals where you've got community referrals, maybe from a child welfare system, other services, and you have an FQHC partner or a clinic partner that can't offer community health worker services because they can't be reimbursed for them. So it's a great opportunity for a CHW CBO and an FQHC to partner together where that FQ identifies these patients who need CHW services and then have a partner CHW service organization that can provide them. So if you have 2 referral pathways, you're always checking the Medi-Cal coverage. If they have the right coverage, then they can begin services, whether that's the community pathway or the medical pathway. There are 2 really important things I want to call out here. The first is that CHW benefit applies to clients or Medi-Cal members who have managed care Medi-Cal, so through one of those 6 managed care plans, and also for individuals with fee-for-service Medi-Cal. So there are very few people anymore who have fee-for-service Medi-Cal. The predominant population in Los Angeles County that has fee-for-service Medi-Cal are children in foster care. They cannot access services like enhanced care management because that is only available through managed care. So the community health worker benefit is critical for people who don't have managed care, who have fee-for-service, because it's one of the very few care management offerings that can help them. So this is a real wonderful thing about this benefit is it's available to both types of Medi-Cal. The other piece that I want to make sure to call out is on the community referral pathway. DHCS has implemented what's called a standing order. In the past, you used to have a licensed clinician, a doctor, a nurse, an LCSW, write an order for someone to qualify for CHW benefit. The state has published now from one of their medical directors a standing order that says if the client meets the eligibility criteria, they're automatically eligible for the community pathway. So there's no need for them to see a licensed clinician to get a request for CHW services. Again, that only applies to the community pathway. The medical pathway still requires a doctor's visit and that written request. So the state's really working to make this low barrier, but in order to achieve financial sustainability, you really have to think about how to make both of these pathways work together. Next slide. So again, thinking about rates and revenue, if we're looking at how much a single CHW costs, including supervision, billing, and the indirect costs, it can be about $115,000. So really, the break-even rate is about $43 for 30 minutes, which is all the more reason that it is important to think about how to maximize both pathways or CHW, the community pathway, plus something else, right? What do you add to it? And so that's what this is talking about. Next slide. So what do you need operationally to become a CHW provider? There are certain staffing needs like having a manager, supervisor, a billing and financial analyst, contract manager, and CHWs with certificates or work experience and certificates in progress. Certainly there's technology like an electronic health record, a system that can bill Medi-Cal, so you can either buy that and have it in your system, you can build it, you can contract it out, ability to do audits and oversight, appointment and service tracking, and being able to document a care plan. You need to have community referral partners. So making sure you have partnerships with things like child welfare agencies, local clinics, hospitals, other partners, and that those agreements and arrangements are either informal or they're contracts or they're MOUs, some shared understanding of how you'll work together. And then training and resources, because CHWs must be certified, they have to have continuing education, they have to have operational training and workflows and job aids. So this is really sort of the nuts and bolts in the 4 different areas of things you'd have to think about. Next slide. All right, so summing it all up, what do we need to think about as we leave today and reflect on whether or not this is a viable option for your organizations? Next slide. So thinking about all the areas where your community health worker workforce can support, whether it's preventive care, engagement in primary care, general care management, perinatal or postpartum care, transitional care, disease management, behavioral health, social drivers, government, and other related benefits. So there are so many places CHW benefit can apply. So really thinking about, do we cover some, all, a few of these, and how can we be of service? Next slide. And then thinking about if that medical pathway is a good fit. So again, if you're a CHW organization, you need a partner that is a clinic, or multiple clinic partners. So do you have existing partnerships with clinics or healthcare providers who would complete the initiating visit and refer clients to you? Could there be an opportunity to co-locate community health worker staff at a clinic or doctor's office? So you would pay the CHW, but maybe they would work out of that clinic. So they would be available whenever someone came in and saw the doctor and was identified as needing services. How would you communicate between the doctor and the medical team and the CHW, especially if the CHW is your employee, but they're working with the clinic? How do you make sure that communication is solid? How do you share documentation back and forth with the medical provider? And how would you make sure that your community health worker engaged in case conferences or multidisciplinary team meetings to help coordinate services? So this takes a little bit more work because we're talking about two different organizations working together, where a CHW is an employee of an outside organization, but really is critical to the work that's happening at that clinic or health center. Next slide. And then we have a little bit of a readiness checklist for you to take back and look at. So have you looked at the DHCS policy guidance? That's a lift in and of itself to read all the DHCS policy guidance. But they have a great CHW benefit website that has lots of information. Do you have policies and procedures? Have you thought about policies and procedures? What would you need to do to support the member? What would you need to do to document a care plan? Who will be available to assist your CHWs? What about core competencies and providing culturally and linguistically appropriate services? So really thinking through making sure we're meeting the needs of the members. And then establishing a training process. So do you have protocols to provide the training for certification? And I know that's why we have partnership with Rosie and her organization, because they do certificates. And then also making sure that there's the continuing education is met, and that's 6 hours annually. So things to think about before you decide to take the jump. Next slide. And then core operational readiness requirements. So again, the CHW certification, Medi-Cal enrollment, we'll talk about that in just a second, billing infrastructure, service delivery infrastructure, and then data collection and documentation, which is probably between the Medi-Cal enrollment and the data collection and documentation and billing. These three administrative parts are probably the biggest lift. You probably have great workforce that does wonderful work already. And so it's really about taking that and translating it into how can we bill Medi-Cal and be reimbursed for our work. So those are the important pieces. Next slide. So this is a great tool that we have created. To become a Medi-Cal provider, you must enroll through PAVE. PAVE stands for the Provider Application and Verification and Enrollment System, I believe. Provider Application, Verification, and Enrollment. This is a website. PAVE is managed by the Department of Healthcare Services. And so this website that we created is a step-by-step guide to help you know how to navigate PAVE. It is very challenging to navigate. If you are applying to become a CHW benefit provider, you must apply through PAVE. The reason for that is because CHW benefit bills managed care, but it also bills fee for service, which is handled by the state. So for that reason, you have to go through PAVE to register as a CHW benefit organization. So this will give you step-by-step guidance. What are the documents you need to have? How do you go through the process? What's the checklist? It'll link some resources. And then also some ECM providers, particularly if they're doing the justice involved population for enhanced care management, they also have to go through PAVE, and doulas have to go through PAVE. So if you have any of those services under your umbrella, they also have a PAVE pathway. So this is a great resource that's pretty new, but super helpful because I know many, many organizations have had trouble with this. Next slide. Oh, there's, yeah, great. Okay, we also have some additional resources on our website. So there is an issue brief that talks about the different provider classes. So there's a section in there on community health workers and community health worker benefit. There's also a slide deck on requirements for the new Medi-Cal provider types. So this one will talk about requirements to become a CHW versus other types of providers under Medi-Cal. And then a primer on the community health worker benefit. So please, you'll get these slides afterward. So you'll have access to the links in here, but we hope that you find these additional materials also very helpful. Next slide. I think that's it. So I wanted to make sure we finished with enough time for questions. If you've had any questions, come in, Rosie, or anything else you wanted to chime in on.
Thank you so much, Mary, for a great presentation. Brought a lot of clarity. I'm sure there's still a lot of questions to be asked, so please go ahead and submit your questions through the menti.com using that code 93991383, and we'll get to your questions in a bit. But before we get to your questions, just want to share some next steps. So we will continue to provide ongoing technical assistance through having these convenings on a quarterly basis. I'll also share some resources that come my way. If you also have resources, please share them with me and I'll share them with everyone. Our next meeting will take place in July of this year, and we will discuss the results from the CHW Billing Readiness and Infrastructure Assessment Survey. Thank you for those who completed the survey. It was very helpful to see those results and where you currently stand as your readiness for CHW billing. So let's go into the questions here. All right. So we have a few of them. Wonderful. Thank you for. Okay, so we have a question here. Yes, the presentation will be sent out. Can a private practice clinic get reimbursed for CHW services? Who should we bill?
When we say private practice, are we talking about non-FQ? I'm assuming we're talking about non-FQHCs, like an individual provider practice. If you're not paid through the prospective payment system, my guess is yes. I would want to go back and confirm that though, because the exclusion that I'm aware of specifically applies with the PPS system that the FQs are paid by. So let me confirm that and we'll circle back, Rosie. It's a great question.
Yes, great question. Next question here. Do we know if hospital encounters in our emergency department or inpatient setting will count as initiating visit for medical pathway?
That's a really good question as well. So to qualify for the initiating visit, it has to be billed under a certain code. I can also follow up with you, Rosie, on that. That's really what they look for. And that's why I know it can't be someone like an LCSW. It has to be a physician visit. I'm not sure if it can be in an ED or an inpatient setting. If it's billed that to the code that's required, perhaps it could work. There are also some special circumstances for community health worker services in hospitals. It's a little bit, there's a little bit more flexibility in terms of that. So I'll also send some follow-up information to Rosie about that so she can share that out with you since many of you are from hospitals. It's a really good question.
Thank you. Great question. Next question. Are Medi-Cal ECM providers qualify as refers to CHW services for the medical pathway?
Not necessarily. So this is, again, the really important thing on the medical pathway is that it must be a doctor, a physician assistant, or a nurse practitioner who is a Medi-Cal registered provider. So a Medi-Cal registered physician or a PA or NP who sees the patient and uses the specific billing code for that visit type. So it can't be an ECM care manager. They wouldn't qualify for this.
Next question. Can you share the state standing order describing automatic eligibility for the community pathway to CHW services, please?
Yes, absolutely. I will send that in follow up. There's a great link. It's right on the DHCS CHW website where it has the standing order and it outlines the eligibility criteria and the authorization.
Thank you. Next question. Could we become a CHW provider and move our stabilized clients from ECM to CHW services?
Absolutely. That is one of the best ways to think about sort of expanding the funding and bringing in more clients. So if you are able to stand up a CHW program with your ECM, you can use ECM as or CHW as a step up. So maybe they don't seem to qualify for ECM, but they need help. So you start serving them in CHW, and then maybe you find out they do meet ECM criteria, or they don't need ECM anymore, but still need some help. And so they could step down to community health worker benefit. Yes.
Great question. Next question. For PAVE certification, is having only one certificate CHW sufficient? If so, can we then do the experience pathway for further CHWs?
Yes, definitely. You only need one to get started. Yes.
Next question. Can an organization contact with multiple health plans to bill for CHW services?
Yes, and that's definitely advisable, especially in LA County where we have so many managed care plans, because your client base probably has mostly 2 or 3 different kinds of Medi-Cal from different plans. So yes, absolutely. It's more complicated because you have to build different plans for different members. But in terms of getting coverage to serve as many people as you can, absolutely.
Next question. Can a CHW do ECM services?
Absolutely. So there is no specific training, certificate, diploma requirement for an ECM lead care manager. So if you have someone who is a community health worker and is certified as a CHW, they can also do ECM. You just need to talk with your managed care plan about any restrictions if that person is also providing community health worker benefit services.
Okay, we have 2 last questions here. I'll go with this one. If our providers are already Medi-Cal enrolled providers with PAVE, am I understanding that an additional enrollment for CHW services need to be completed?
Yes, because the enrollment for CHW services has to be done at the organization level. So it's a really good question. If you have individual providers that are already enrolled with PAVE, your PAVE submission for CHW has to be at the organization level. So you'll need your organizational NPI.
We got some more that just came in. So we're out of time. Is it okay to go over just these last 3?
Yeah, sure thing.
Yes. Okay,
Yeah.
thank you so much. Oh, there's some more coming in. Any guidance for FQHCs on what to ask their medical groups for CHW services and getting reimbursed for these through those contracts?
So I can tell you right now that FQs cannot get reimbursed for CHW benefit. I think some FQs offer CHW benefit like services already through different models. I know several health centers have CHWs on staff. I think it is important to think about if you are a CHW community-based organization, how could you approach an FQ? Or if you're an FQ that's interested in having a partner, how do you work together? And so there's that slide that talks about the thoughts about implementing the medical model. I would really start there. And I think internally at the FQ, it's really important to think about what would it look like to have a partner organization work with us? What does that mean for our EHR access? What does that mean for our medical team communication? So things like that, because it's a big commitment on both parts for the CHW organization and also the clinic.
Next question. I noticed the billing code is the same for MCHES, which stands for Master Certified Health Education Specialist, or CHES, which is Certified Health Education Specialist. If our CHWs are CHES certified, can we still bill for CHW?
It's a good question, and I suspect that comes down to the modifier. So when you bill for CHW services, there's also a specific modifier that you have to use that indicates it's community health worker benefit. So if your CHW is certified and also they're a CHES or an MCHES, it should still be okay. Your billing should note with the appropriate modifier that it was a CHW service, not a health education service.
The distinction.
Yeah.
Next question, can a CHW do CPSP visits, Comprehensive Perinatal Service Program visits?
I I need to take that one back. I want to double check that. It is not super clear in the program guidance, so I'll put that on my list for follow up with you too, Rosie, so we can get some clarity.
Wonderful. And last but not least, Mary, how can we contact you for consulting services if you're currently offering these?
Sure, I will put my email in the chat. You're always welcome to email me. And there are, I do this work, and then there are some great colleagues I have that do this work as well. So please reach out, and you can also reach out to Public Works Alliance for sure. Yep.
Wonderful. So this concludes our presentation for today. Thank you so much, Mary, for bringing this wealth of knowledge of your experience and all the great work that you've done over these years, and to share such fruitful information. I hope this provided more clarity for our group here, more guidance, and we are very grateful for your participation. Everyone here too, very grateful for your participation. Please reach out for any questions. I will send the recording, the presentations over, and I'll continue to check in with everyone from time to time, and then I'll send an invitation for the next convening. So thank you all for your time. Really appreciate you. Enjoy the rest of your day. Thank you.
Thank
Thank
you.
you.
Thank you.
Excellent.
Thank you, everyone.
Excellent. Excellent.
Thank
Thank
you so
you.
much.
Thank
Bye-bye.
you.
You're welcome. Thank you.
Great work, Rosie. Thank you so much for everything.
Thank
I
you.
arrived just in time. Awesome.